Chapter 19, Cesarean Birth. The rate of cesarean births has been climbing again. In 2013, the rate was over 32% of all births with cesarean section. This is due to many factors which include maternal obesity, decreased use of forceps or vacuum-assisted deliveries, and fear of litigation among the providers. Healthy 2020 started an initiative to decrease the rate of primary, which is the first time C-sections, to 23.9. One option for a woman who has had a cesarean section is to have a VBAC, which is a vaginal birth after cesarean, for her next birth. There are risks involved with doing a VBAC, and they include uterine rupture at the incision site. Most cesareans are performed using a low transverse abdominal incision. In cases of a true emergency, a classical vertical incision on the abdomen is used. In order for a woman to attempt a VBAC, she must have the low transverse incision to decrease the risk of uterine rupture. Many providers will not attempt a VBAC if the woman has had more than 2 cesareans, either, as this also will increase that risk for the uterine rupture. Indications for a cesarean section include dystocia, which is a slow or difficult labor, cephalic disproportion, which means the fetal head is too big for mom's pelvis inlet, maternal disease, maternal active genital herpes, non-reassuring fetal heart rate, prolapsed umbilical cord, the fetus is in the breech or transverse position, placenta previa, placenta abruptio. Maternal risks for cesarean delivery include any related risk to other surgeries. Fetal risks include transient tachypneic of the newborn, which we're going to talk about when we talk about our babies more, persistent pulmonary hypertension of the newborn, and laceration, bruising, or fractures caused by the delivery. In non-emergency situations for cesarean birth, standard preparations are made. This includes insertion of an IV if not already done so, and fluids are started. Maternal labs to check for coagulation, rule out infection, blood type, and possibly other labs for baseline info. If these labs were already collected, if the woman was in labor, they will just use those labs. Placement of a Foley cath, medications to decrease the stomach acid, clipping of the pubic hair are standard measures. Of course, being sure consent is signed and the patient is informed will be done by the provider. The type of incision is typically the low transverse or a bikini cut if it's not an emergency or a previous vertical abdominal scar is in place. The vertical incision is used for those emergency situations because it's a quicker route to get the infant out. Box 19.2 lists before and after cesarean nursing considerations. Protocols can vary between institutions, but these are pretty standard. At some facilities, it's the OB staff who prep and are part of the OR team during cesarean sections, and in other facilities, it's the OR staff that performs those duties. Variations can also occur if it's an emergent situation. In those cases, delivering the infant quickly is a priority, and many times, most of the considerations are bypassed. Support is crucial to the patient and family. If a cesarean is planned event, the family and patient may seem to have more control and have less anxiety, but this is not always the case. Any surgical procedure can be stressful on the patient or the family. Using therapeutic communication and helping them with their fears can help put their minds at ease. Sometimes the patient and family do not receive the support or education if it's an emergency situation. Try to dedicate one person to just provide that education and support the patient and family during this time. As time permits, be sure to answer all questions and let them voice their concerns. Teaching should occur pre-op when it's feasible and post-operatively. If time permits, education should be given on all procedures that are occurring prior to surgery. This includes what medications they're receiving and why, the importance of the Foley, continuous monitoring of the fetus until time of delivery, etc. It also will help to educate on what to expect in the OR. Many times the room is colder, they will strap down her arms for safety, what to expect if having a spinal anesthesia, and that she may feel some tugging while getting the infant out. Also explaining there will be a warmer for the infant in the OR, and many times the infant may go to the warmer for a quick assessment and then brought over to mom to see and possibly hold. Some facilities allow skin-to-skin in the OR while the provider finishes up the surgery. Post-op teaching can begin during the pre-op period if appropriate. If mom is anxious, then waiting until after is a good idea. Reinforcement will need to be done after as well. Teaching on pain control, when she'll be getting out of bed, when will the Foley come out are a few things. Also teaching about the importance of coughing and deep breathing and ambulating when allowed. Educating on the importance of sequential suppression devices that will be on her legs to prevent DVTs. Safety is always a priority in patient care. Most women are allowed clear liquids once she's awake and alert enough for intake. Nausea is a common side effect of anesthesia, so being certain she can tolerate the clear liquids first is a good nursing judgment. If tolerated and bowel sounds are present, she usually is advanced to a regular diet if no other issues are at hand. Also educating that since the nausea can occur, trying to keep their food choices to non-greasy foods is a good idea. Positioning is another safety concern. Many times it can take a few hours to have full sensation back in her lower extremities, so patting bony prominences should be done. Placing a wedge or pillow under her hips so she is not flat on her back can also promote safety and comfort. Being mindful of the Foley tube position is so it's not kinked or under the leg, which will enhance drainage and decrease her risk for UTI. Routine postpartum care is provided to the cesarean patient. You still need to assess her fundus and lochia, just like a vaginal delivery. You will do routine post-op care like you would any patients during the head surgery, including vitals, lung and bowel sounds, assessing her incision, eyes and O's are a few areas. For the patient who had spinal anesthesia or an epidural, you must assess for return of full cessation in her lower extremities. For most women, the sensation is returned within 1 to 2 hours post-op. Assessing vitals is crucial as this can cause a change in that patient's status. Each facility will have a protocol of how often they need to be done. Monitoring respiratory status is crucial, also since respiratory depression can be a side effect of medications. Pain relief is crucial at this time. Some women are giving a longer acting narcotic with their anesthesia, so they do not have much pain right away. Some providers will order a PCA pump for patients, while others will either have IV or oral pain medication available. Many times NSAIDs are ordered for pain relief and are useful in reducing pain and inflammation. Ketorolac or Toradol IV is often the NSAID of choice for the first 24 hours. After that, they will give ibuprofen. Remember, you cannot give more than one NSAID at a time, so never give oral ibuprofen if she is receiving Ketorolac. Pain control needs to happen the whole time she is in the hospital. Once she starts getting out of bed, her pain will probably increase, so being sure to medicate her prior will help. Many times we encourage them to take pain meds routinely while hospitalized just to keep that pain under control.